It's a real pleasure to welcome Dr. Lynne Mofenson tonight as our featured speaker this Public Health Week. Dr. Mofenson retired from a 26-year career at the Kennedy Shriver National Institute of Child Health and Human Development in 2014, and is a pediatric infectious disease specialist by training, who graduated from the Albert Einstein School of Medicine and then did her pediatric training at Boston Children's Hospital, and then pediatric infectious disease and a chief residency in pediatrics at UMass. After that, she eventually came to the Massachusetts Department of Public Health in 1984 and served as director of the Division of Communicable Disease Control and assistant commissioner between 1984 and 1989, which was quite a tumultuous era in public health and at the Massachusetts Department of Public Health for a variety of reasons, not least the impact of AIDS on public health and how we practice public health and medicine. And in 1989, she decided to join the National Institutes of Health, and while at NICHD, she led the branch that dealt with pediatric, adolescent, and maternal HIV infection, and was overseeing multiple research projects, both national and international, that you'll hear about. Some of the important ones, well, they were all important, but some of the most important ones this evening. And she now is a senior advisor with the Elizabeth Glaser Pediatric AIDS Foundation. And I have to say, on a personal note, I first met Lynne when she rotated through pediatric infectious disease at Boston City Hospital and was immediately impressed by her brilliance and conscientiousness. And she was amazing, quite frankly. And I also have to say that in a sense, if it wasn't for Lynne Mofenson deciding to go to NIH and deciding to do that when she did, I think I can say I would have never had a career in public health. Because, all of those contingencies came together. So for that, thank you, Lynne, and welcome, and thank you for joining us this evening.
You're welcome. Should I share my screen?
Yes.
Okay. And I'll go to full. Okay, let's see if I can close this. Okay. Good evening, everybody. It's a pleasure to be here. I'm going to talk about prevention of perinatal HIV infection from epidemic to potential elimination. And I want to start, it may be too simplistic, but I do want to start with some definitions. Human immunodeficiency virus, or HIV, is the virus, and infection can be asymptomatic initially. Acquired immune deficiency syndrome, or AIDS, is the symptomatic disease that's caused by HIV infection. CD4 immune cell is the lymphocyte that's infected and killed by HIV that causes immune deficiency with low CD4 count. And finally, antiviral therapy is a combination, usually of 3 anti-HIV drugs for treatment of HIV infection and to lower virus levels in blood and body as much as possible, just so that you understand what I'm talking about as I go along. So the first cases of pediatric AIDS were reported to the CDC in 1982, about 18 months after the first case report in adults. And initially it was reported in pediatric hemophiliacs and transfusion recipients, but then in children without such risk factors. And by 1983, reports of AIDS among children born to parents with recognized risk factors for AIDS were published from New York, New Jersey, and Florida. So in the mid to late 1980s, if a woman was infected with HIV, 1 in 4 of pregnant women living with HIV had an infant infected with HIV, 25%. It was recognized that most pediatric HIV infections occurred during transmission from mother to child, although the exact timing of transmission was unclear. And by the early 1990s, in the United States, more than 16,000 perinatally infected children had been born, and there was a critical need for prevention. Now, how does perinatal transmission occur? Transmission of HIV from a mother living with HIV to her baby can occur in 3 ways. First is during pregnancy, where virus in maternal blood can cross the placenta and infect the fetus. Second is during delivery, through contact with virus and infectious secretions in the vagina as the baby is delivered, or through breaks in the placental barrier during labor, resulting in infection. And then finally, through breastfeeding, through ingestion of virus that's present in breast milk, either as free virus or cell-associated virus. So in the late 1980s, there were no specific interventions to prevent transmission other than for a woman to know her HIV status, and if infected, to not get pregnant, and if pregnant, to not breastfeed. Additionally, untreated HIV in children had extremely high mortality. And on the left, you'll see a graph showing you the cumulative proportion of surviving children from Jackson Memorial Hospital in Miami. And you can see that by age 2 years, mortality was 25% in the US. And on the right, you can see a graph showing you the cumulative probability of death in children in Africa. And here you see that by age 2 years, mortality was 52.5%, much higher than in the US. Now, 1987 begins the HIV treatment era, and zidovudine, or AZT, was approved by the Food and Drug Administration in March 1987 for treatment of non-pregnant adults with HIV who had low CD4 counts. So given the availability of AZT, the association of perinatal transmission with maternal HIV viral load, and the very high mortality of pediatric AIDS, pediatric and obstetric researchers proposed giving AZT to infected pregnant women to reduce perinatal transmission. However, giving a potentially toxic drug to pregnant women and exposing their fetuses was very controversial, and the Food and Drug Administration held a public meeting to discuss the ethics of giving AZT to pregnant women before allowing the perinatal prevention trial, PACTG-076, to go forward. So the AZT regimen in PACTG-076 was actually designed to target multiple potential time points of transmission. We figured we had one chance and one chance only to be able to do this. It enrolled HIV-infected women who had CD4 counts greater than 200, who therefore did not require treatment for their own health, which is you have to have a CD4 count less than 200 to get AZT at that time. So AZT was given 5 times a day during pregnancy to target transmission occurring in utero after the first trimester. It was given intravenously during labor and delivery to target intrapartum transmission by providing pre-exposure prophylaxis to the baby. The drug goes in the mother, it passes to the baby, and the baby has drug on board at the time that they're exposed during delivery. And then finally, AZT was given to the infant 4 times a day for 6 weeks to target any postpartum transmission, providing post-exposure prophylaxis against any virus that the infant may have swallowed during birth or come through during placental disruption. So the DSMB interrupted this trial early in February 1994. It's the 30th anniversary of 076, and it interrupted and stopped this trial early because The placebo group had a transmission rate of 26% compared to the AZT group, 8%, with a remarkable 68% reduction, more than we had thought that we were going to see. So this was actually the first demonstration that treatment can provide prevention, or TSP is called today. So we moved rapidly from research to implementation in less than 1 year, and that usually doesn't happen. So we have in February, the DSMB stopped the study. We had press coverage within a couple of days. And in March, a public health service task force was set up, which I headed, and we issued guidance in April, only 2 months later, for use of AZT in pregnant women. We then held a public hearing in June to debate guidelines on who should get AZT and about testing of pregnant women. And in August, we expanded our recommendations for AZT use to say it should be used by all HIV-positive pregnant women for prevention of perinatal transmission. And 4 days later, the Food and Drug Administration approved new labeling for AZT to include prevention of perinatal transmission, the only drug that has that indication. It wasn't until November that the results were actually published in the New England Journal. And then in December, Medicaid coverage for AZT to prevent perinatal transmission was required in all states. And this rapid translation of trial results resulted in a tremendous effect on perinatal infection in the US. So this shows you the estimated number of perinatally infected infants born each year in the US between 1978 and 2013. You can see we peaked around 1990, and you can see the 1994 Public Health Service recommendations, 1995 CDC guidance for universal HIV screening. Within 3 years, between 1994 and 97, there was a 65% reduction in new perinatal infections. Within 10 years, an 88% reduction. And through 2013, a 97% reduction in new infections. And in 2019, there were only 32 infants born with perinatal infection in the US. So after 1994, as interventions to prevent perinatal transmission in resource-rich countries began to be implemented, attention turned to the developing world where most pediatric infections were actually occurring. And by 1994, 1 million HIV-infected infants were estimated to have been born globally. By 1999, this doubled to over 2 million, with over 500,000 children under age 15 becoming infected in 1999 alone, most through perinatal transmission, and 90% in sub-Saharan Africa. And just a note that transmission rates are nearly 50% in breastfeeding populations in Africa. So the AZT regimen used in 076 was viewed as too complex and expensive for the developing world at that time. So the initial focus of trials was to develop simpler, shorter AZT regimens given during pregnancy. And after shorter regimens were identified, studies of combination regimens began. And then following success to identify regimens to reduce in utero and interpartum transmission, and in recognition that breastfeeding was critical for child survival in the developing world, you couldn't just say don't breastfeed. The focus then turned to preventing breastfeeding transmission using either infant and or maternal antiretroviral drug prophylaxis during breastfeeding. And I'll give you a brief run through the evidence road for prevention of transmission. In 1994 here, you see PACTG 076, the AZT regimen, and in green is formula feeding, and in purple is breastfeeding. So first we had several trials looking at shorter regimens of AZT, 50% efficacy with only 4 weeks, but noted that this efficacy declined in breastfeeding, and efficacy was better with longer AZT. In 1999, there was a remarkable study showing that you could give a single dose of nevirapine, an anti-HIV drug, to the mother during labor and a single dose to the baby, and it had 48% efficacy in preventing transmission. Then people began to say, well, what would happen if you put these two together? And if you put AZT and single-dose nevirapine together in a formula-feeding population, your transmission rate was only 1%. And in breastfeeding populations, it was low, but had decreased efficacy. So we began to look at ways to prevent breastfeeding transmission, initially using infant antiretroviral prophylaxis with nevirapine, and the longer prophylaxis was better. It was a highly effective regimen. Then looked at giving mothers triple therapy during breastfeeding, which was also found to be effective, with both maternal and infant prophylaxis having similar efficacy. And then probably the last trial on perinatal transmission that will be done was the PROMISE trial, which looked at prolonged maternal antiretroviral therapy during pregnancy and during breastfeeding for up to 18 months, and transmission here was only 1%. So with this, there was an evidence-based evolution of the World Health Organization recommendations for prevention of mother-to-child transmission. So in 2001, this is prior to PEPFAR, there were no recommendations for treatment. There was actually no treatment available in Africa. And for prevention of transmission, the very short course AZT or single-dose nevirapine was recommended. In 2004, PEPFAR began, and treatment began to become available in Africa, limited to people with a low CD4 count, and these combination regimens of AZT and single-dose nevirapine were recommended for prevention of mother-to-child transmission. 2010, those breastfeeding studies became available. Also, more treatment became available so that you could start at a higher CD4 count. And two options were available, either giving the mother AZT and the infant nevirapine during breastfeeding, or giving the mother triple drugs during pregnancy and breastfeeding. 2013, we began to move to starting antiretroviral therapy at higher CD4 counts, even without symptoms, and moved to providing ART for all pregnant and breastfeeding women. 2016 moved us to where we are today, with treatment for all, regardless of CD4 count, through generous donations from PEPFAR, and lifelong treatment for all pregnant and breastfeeding women. And today, in 2021, the recommendations for WHO are to universally test and treat using a high potent antiretroviral called an integrase inhibitor, and lifelong treatment for all pregnant and breastfeeding women. So there was a move to more effective potent antiretroviral drugs, extending coverage throughout the transmission risk period, including breastfeeding, as well as treatment for the mother's health, not just for prevention of breastfeeding transmission. So in the post-AZT era, what have we learned? So first, we know that HIV viral load in the mother is a critical determinant of perinatal transmission. And the goal is to attain undetectable virus in the blood. And here you can see the percent transmission and delivery plasma RNA, and you can see the remarkable decrease in the risk of transmission as plasma RNA goes down. We also know that combination more potent antiretroviral regimens are more effective than one or two drugs. And this graph shows you the percent transmission in people getting no antiretrovirals, AZT alone, 2 drugs, and finally potent 3 drugs. And in the 1990s, you had to take up to 20 pills a day. Today, you can take as little as 1 pill a day that has 3 drugs in it. We also know that longer duration of treatment during pregnancy is more effective than starting later in pregnancy, as shown on this graph. As duration of treatment during pregnancy increases, transmission decreases. And perinatal transmission rates are near zero if the mother is on treatment that fully suppresses the virus starting before pregnancy, with sustained suppression throughout pregnancy and postpartum. And this is from a study in France looking at women who started antiretrovirals prior to conception and their delivery viral load. And there were no perinatal infections in over 2,600 women on treatment pre-conception and an HIV viral load less than 50 or undetectable at delivery. So we now know that maternal treatment with potent regimens is highly effective for preventing perinatal transmission, but that duration is important, and that transmission is almost eliminated in women on suppressive treatment before conception and who sustain viral suppression during pregnancy and breastfeeding. So can we reach elimination of perinatal HIV? So there are a number of challenges, and I'll talk a little bit about the US. So between 2014 and 2018, perinatal transmission declined by 54% in the US. However, significant racial and ethnic disparities exist, and you can see that perinatal infection rates are highest among Black and African American individuals, then Hispanic Latino individuals, and lowest among white individuals. New perinatal infections in the US are occurring primarily in the South. In the light green, you see states with an incidence of 2 to less than 4 per 100,000. And in blue, 7 states with incidence greater than 4 per 100,000. And among the 16 states with high incidence, 10 were in the South, including Washington, D.C., around where I live. And this has persisted in more recent data. So what are the major barriers to elimination in the US? And these are a number of different papers, and you can see common factors associated with residual perinatal transmission in the treatment era. And that includes late or no prenatal care, late HIV testing and diagnosis, first acquiring HIV during pregnancy, no treatment or short treatment during pregnancy, having detectable viral load at delivery, maternal substance abuse, and breastfeeding. And there is a common pathway for most of these. These barriers impact on achieving viral suppression during pregnancy and hence on risk of transmission. And also racial disparities exist in the United States for many of these factors, such as prenatal care. So what about challenges globally? So globally, over 3 million new infections have been averted with maternal treatment since 2000. So you can see here in the light green that represents new infections that are averted, and cumulatively 3.4 million new infections have been averted in treatment in children due to maternal treatment. However, treatment coverage in pregnant and breastfeeding women has stalled since 2018. You see 2010, only 48% of women were receiving antiretroviral therapy, increasing to 82% in 2018, but then there's been no real change in coverage since 2018. And you ideally want this to be 100%. Additionally, coverage varies considerably by geographic region. And you can see Eastern and Southern Africa are doing very well, 93% coverage, but West and Central Africa, not so good, 53%. Middle East, North Africa, 22%. And the decrease in new child infections subsequently has also slowed. And this shows you new infections among children. And here you see here in 2002, the availability of treatment through PEPFAR, you can begin to see a decline from the peak of 530,000 infections with availability of treatment. Then we moved to 2010, universal treatment recommendations, a further more rapid decline, but there were still 130,000 new pediatric infections estimated in 2022. And while this is a 58% decline since 2010, since 2015, the decrease in new infections has only been 10,000 a year. And at this pace, our reach to the WHO 2020 target of 20,000 is going to take us more than a decade to reach. So the World Health Organization has a global target for virtual elimination of new perinatal infections, defining that as a perinatal overall transmission rate of less than 5% in a breastfeeding population. And this shows you 6-week in green and breastfeeding transmission in orange in most of the African countries in 2019. And you can see only 4 countries have achieved this virtual elimination number, and that most of the infections are occurring postnatally through breastfeeding, accounting for a significant proportion of excess perinatal infections. So there are 3 primary missed opportunities for preventing perinatal transmission. And up on the top here, you see children infected during pregnancy, and on the bottom, children infected during breastfeeding. So the first is the mother didn't receive treatment during pregnancy or breastfeeding. That's the yellow. It's more common during pregnancy than breastfeeding. And this is usually because she doesn't know that she is actually infected because she wasn't tested. The second is incident HIV infection occurring primarily during pregnancy, but during breastfeeding, but also during pregnancy. And then lastly is dropping off treatment with a rebound in HIV viral load. And the postpartum period is particularly challenging here, and it is particularly dangerous in countries in Africa where breastfeeding is needed for child survival. So these are the primary missed opportunities, and there are some potential solutions. So if the mother didn't receive treatment during pregnancy or breastfeeding because she didn't know HIV status, well, clearly we need to improve HIV testing during pregnancy and breastfeeding globally. So if a mother tests HIV negative on her first test, then you repeat the test in the 3rd trimester. And then if she is breastfeeding, repeat the test every 6 months while breastfeeding. This has been in particular hard to achieve in African countries, the repeating testing during breastfeeding. So incident infection during a breastfeeding or pregnancy, we need to improve HIV prevention. And there is effective pre-exposure prophylaxis with a single drug taken every day can prevent HIV transmission. So we need to improve uptake of PrEP and use in women. And more recently, in the last year, long-acting injectable pre-exposure prophylaxis has become available, where a single injection of a drug called cabotegravir, given once every 2 months, can reduce the risk of sexual transmission to almost 0. However, it's not being used in pregnant and breastfeeding women. So we need to implement innovative long-acting HIV PrEP modalities in pregnant and breastfeeding women. And then finally, for women who dropped off treatment, you have viral rebound, particularly in the postpartum, we need to improve retention and use potentially better tolerated potent medications. So for example, particularly in Africa, combine same-day maternal and child care to improve retention, so that both mother and child are seen on the same day. They don't have to pay for transportation on separate days. They can be seen in the same clinic. Newer antiretrovirals may allow less frequent administration, and there are now long-acting injectable treatments, cabotegravir and rilpivirine, that can be given once every 2 months. Again, this is available, just started in the US, not yet available in Africa, and hasn't been used in pregnant and breastfeeding women yet. So we need studies for that. So in summary, in the 30 years since PACTG 076, we've learned a great deal about how to prevent perinatal transmission, and our substantial successes have led to the aspiration that we could eliminate new pediatric HIV infection globally in the near future. But we've also learned that we can't be complacent about our successes. Progress has slowed primarily due to continued incident infection in women and implementation challenges, such as the need to improve identification of women with HIV and to support them to remain on treatment. And exciting new innovations in treatment and prevention over the past year now hold the promise of helping us reach this goal of an AIDS-free generation. And thank you for your attention, and happy to answer questions. And I will stop sharing. There we go.
Thank you, Lynne, for the great summary of 30 years of progress. And we're opening up to questions. You can put them in the Q&A. I think I got the chat working, I'm not sure. But feel free to actually you can put up your hand too, and I can recognize you. I have a question though. Recently there's been some discussion about continuing controversy over breastfeeding despite antiretroviral therapy. And if we really believe that undetectable equals untransmissible, why would there still be controversy when breastfeeding is such a important?
Yeah, I think the controversy is now in the US. And I don't think we can completely say undetectable equals untransmissible for breastfeeding, because there are a few cases of transmission despite the mothers having undetectable virus. And that may be because cell-associated transmission is occurring and the antivirals can't get into the cell. But because you can reduce transmission to well under 1% through breastfeeding with the use of antiretrovirals, in the US, up until a year or so ago, it was recommended that if a woman was HIV infected, that she not breastfeed her infant, because we have safe infant formula available. It's relatively inexpensive. And it's not as essential for child survival as it is in Africa. But with the advent of new antiretrovirals that are highly potent and potentially able to make the woman completely undetectable, there's been some change with the idea that while breastfeeding may not be completely recommended for HIV-infected women in the US, that if a woman wanted to breastfeed, she could be allowed to breastfeed if she's on treatment and remains suppressed. So helping the woman make an assessment, a risk-benefit assessment for herself, and helping that woman stay on therapy and remain suppressed. So that's really what the controversy has been.
Louis Faison or possibly Lynn Eckert has a question or comment.
Hello, can you hear me?
Oh, it's
Yep.
actually Louis. Okay.
Okay.
Yes.
Well, thank you, Lynn, very much for that. That's fabulous. What a career opportunity for you, and you made the most of it. And for millions of children, it's unbelievable what a career that is, and how rewarding that must be, not just for you, for all of us, pediatricians and primary care people in particular, and intensive care people who took care of these children in Africa in particular, and the States. So my question would be, when you look at the United States and you look at Africa, is there a health system such as in those states that still have HIV somewhat higher than other states, primary care, the role of primary care, you think of pediatricians, family doctors seeing infants and children during those breastfeeding months, more emphasis, let's say, in primary care in the United States. In Africa, it might be village health workers or other healthcare providers. Do you see a systematic change that needs to take place in the provision of healthcare in general that would affect HIV transmission? Thank you.
Well, that's a difficult question. I want to just step back and thank you for all of your compliments, but this is not a one-person achievement. This is work of hundreds of thousands of people, both in the US and in many other countries, working on preventing perinatal transmission and trying to make sure maternal health is emphasized. In the US, I think our health system problems are both fee for paying for services, and the fact that services are unevenly distributed, and that we've got racial and ethnic disparities that really have perpetuated the remaining infections among minority individuals, and we really need to fix that. And that's a health systems problem, not just for HIV, but for pretty much everything. In Africa, it's a little bit different, and I agree with you. community-based antiretroviral therapy delivery, community-based assistance for mothers to be able to stay on their therapy is really important. And an important piece has been peer-to-peer work. So there's mother mentors, and these are mothers who are infected, who then and on treatment, and they then can counsel women who are newly found to be infected and help them through staying on treatment and having a healthy child. I think that's kind of answered your question.
Yeah, thank you.
And to what extent, looking at access, looking at adherence, to what extent is any remnant of concern about toxicity of antiretroviral therapy a barrier to women taking medication?
So I didn't talk at all about that. I had shared with Al a talk I had given for a medical grand rounds that covered issues around toxicity. So there is a lot of controversy, and part of the problem is that there's not a really good systematic way of collecting that data. And also pregnant women are excluded from most phase 1, phase 3 studies, so that you have a drug approved and used in the general population with no data in pregnancy. You don't know if it's the right dose. You don't know if there's any special toxicities in pregnancy. But once you put that drug out there and it's taken by women, women get pregnant. And so one emphasis has been on trying to get studies in pregnant women pushed back to the phase 3 period, so that you have data on pharmacokinetics, you have data on dosing, and some preliminary data on safety. To date, there have been studies that have been following children born to HIV-infected women on treatment. In the US, it's called the Pediatric HIV/AIDS Cohort Study. It's been ongoing and following of kids born since 1994. And in general, no toxicity has been found in kids who've been exposed to HIV and exposed to antiretrovirals and are uninfected. So that is good news, but it's still small numbers. And there was a big controversy about dolutegravir, which is a new antiretroviral and integrase inhibitor, that there is a large birth surveillance study in Botswana, extremely well done, funded by NICHD, that had in a preliminary look in 2018, looking at birth defects among women who were on antiretrovirals while they were pregnant, found a potential increase in neural tube defects with dolutegravir use prior to conception. The problem here was that it was only 494 exposures, but it caused a huge fuss about dolutegravir. People stopped giving it to women in general. And as more exposures were documented, as you have more exposures, when they got to 2,000, 3,000 exposures, the rate that they saw, which was 0.9%, decreased to 0.1%. And it turns out that there's no difference in neural tube defects between women receiving dolutegravir prior to conception or non-dolutegravir prior to conception, with the problem being that there were too few reports to be able to discern that. So we need to have better surveillance.
I have a question. It says Suet-kind. It could be Suet-kind or
Hi, Sue.
Paulette-kind.
Well, it's door number 2.
Hi, Paul.
Hi, kudos to you, Lynn, and to the museum for making this available to us. It's a marvelous presentation. I'd like to follow up on Al's question and regarding reasons for under testing, if you will, or the need for greater amounts of testing. How much of a role does stigma in terms of knowing one's status play in that gap?
Well, I'm sure you remember the late 1980s when we had those anonymous testing centers where, we wouldn't take people's names because they would be so afraid of being found to be HIV positive, and there was no treatment. So really, why would you want to know that you were HIV positive other than to potentially prevent transmitting to other people? But when treatment became available, I think both in the US as well as Africa, the amount of stigma has decreased. And the more that people see people surviving, having normal lifespans, my hope is that stigma will decrease. In Africa, at least, I don't believe the testing problem has to do with stigma. I think it has to do with test availability. And that it, while it is, quote, universal, people run out of test kits, or they don't want to test people. There's still some of that in the US, but in the US, the guidelines are for universal testing of all pregnant women. And that's pretty much followed. I hope that answered your question, kind of.
Thank you very much.
Louis, did you have another question?
This is Lynn. I have a
Lynn.
question. Lynn Eckert. Hi. Lynn, thank you very much. Very well done. One of the things that you brought up is giving of an injectable preventive medicine so that for 2 months you would not get HIV, if I have that right.
Mhm.
Has anybody thought, are people thinking at all about what that could mean in terms of a longer term vaccine that could be given to anyone?
Oh, of course. I mean, I think the first issue is there are a number of different long-acting formulations that are becoming available, and there is a new drug, lenacapavir, which is currently being studied for prevention, that you would give one injection subcutaneously every 6 months. So that's an every 6-month prevention, which is quite amazing. And people are trying to get to the point where you can have, a 2 or 3 time injection. It would be better if it was oral, medication for not just prevention, but for treatment as well. Also, the use of antibodies, broadly neutralizing antibodies, has come back up. Back when I joined NICHD, we were using general immune globulin, IVIG, to prevent infections in infected children before we had therapy available. Well, now there are antibodies that can neutralize HIV, and the idea there is that you would be able to give an antibody that would then protect you for 2 months, 6 months from becoming infected, and that you would be able to use that for treatment as well. The problem is that HIV's surface changes very rapidly, so that there is not one broadly neutralizing antibody that covers all of the variants around, so that you would probably have to have 2 or 3 or 4 broadly neutralizing antibodies to be able to have adequate prevention. But that's all under study now.
Would you see any something like the HPV vaccine now? Do you ever see one similar?
Great, that would be great, but I don't know that we've gotten to an HIV vaccine yet. I think the studies with the broadly neutralizing antibodies have, excuse me, if that works for prevention, then you go backwards from that and you say, okay, well, that's the antibody a vaccine would need to produce. And so you then make an antigen that would make the body make that antibody. So there's a lot of studies looking now at these broadly neutralizing antibodies and trying to figure out what kind of vaccine would best produce those antibodies and whether that would be protective. But, you know, we've been talking about an HIV vaccine for like, what, 40 years, 35 years? So I don't think anything is coming very soon. But I think the passive immunization with the broadly neutralizing antibody is more promising for at least a short-term kind of immunization.
Thank you.
I have a distinct memory of the day that Margaret Heckler had that press conference where they announced the identification of HIV, and hearing a colleague being interviewed and saying, "Oh, this is such a great advance. This is wonderful. We'll have a vaccine in 18 months."
Yeah.
Oh, should have said
Unfortunately,
that.
we did it with SARS, but we haven't done it with HIV yet. But they are looking at mRNA vaccines for HIV now, so maybe there'll be more success with that.
There's a comment from Donna Picard. Thank you for this well-organized update. As a nurse with Mass Care and PAC-G Impact 1992 to 215, I have been wondering where we are today. Interesting that prevention is stalled, but I'm glad there's still work being done.
Yeah, I think the stall in prevention that I talked about, I mean, in the US, we have problems, but we have pretty much reached a pretty virtual elimination with very, very few infected children born. Now, of course, that requires continued work of public health and physicians to make sure people are tested and get on treatment, et cetera. The big stall on prevention has been globally, and you know that has multiple etiologies, which I talked about in my talk. But yes, there's still a lot of work being done.
If any other questions, comments? One thing I've been thinking a lot about is the Pediatric Spectrum of Disease Project and the screening that was going on in the 80s into the 90s that, you know, was, I think, brilliantly designed. So for people who don't know what I'm talking about, basically you could take newborn screening specimens and de-identify them and do things with them to prevent any kind of connection with an individual baby and know exactly how many children were born in the state to women with HIV infection, because you could measure their antibodies in the baby's blood. And then another project that I also think was brilliantly designed was, and I'm talking about Dr. Mofenson's involvement here, was a pediatric spectrum of disease as it was done in Massachusetts, which recognized that babies with HIV infection and babies who were born to HIV infected mothers were most likely going to get their care in a set number of programs in the state. So putting surveillance into those programs would allow a connection, an understanding of what happened to the babies born to HIV infected mothers.
So Lori Kunchis, if she's on, this is Lori Kunchis' work, really, the PSD project. And of course, the newborn screening was first done, Rod Hoff and George Grady from the Massachusetts lab developed that newborn screening technology. So Massachusetts has led the way.
And Laurie apparently couldn't make it, but George Grady is in attendance.
Hi, George.
I don't see other questions. And thank you so much. This was really a great summary, a great update on a topic that people, you know, I come to realize that this is a good example of public health. When something's prevented, it doesn't draw people's attention. So the the wonderful absence of so many HIV infected children. You know, looking at how we used to think about this in terms of not only HIV infection in the children, but in children living with HIV infection. Unfortunately, in those days, dying from HIV infection is the whole AIDS orphan phenomenon in terms of children infected or not having parents. So,
Well, one comment I wanted to say about HIV, and that is the recurrence of syphilis. You know, if we take our eyes off of all the prevention that we put in place for HIV, we can see the same thing that we're seeing with congenital syphilis, a resurgence. And so it's really important that funds don't get taken away because you've had a success, when that success relies upon continued surveillance and public health interventions. So just a comment to end things.
yes, and I think that's a perfect ending to this. And thank you again. And it's great to see you.
Yeah.
And all the best. And
Thanks, Al. It was a
Keep in touch.
pleasure. And hi, everybody. Bye, everybody. Thanks.
good night, everyone. Thank you for attending. This has been recorded and will be available on the Public Health Museum website. And I encourage you to tell your friends to look at it and to visit the Public Health Museum and support the Public Health Museum. Good night.
Good night.
Thanks, Al. Nice job.
Okay. Let me stop.